Then the last way that some people, I'll say, will learn, the reason I say that, we've got some really good speech therapists here now, which we didn't have 5-10 years ago. But on the other hand, I don't think many people are all that knowledgeable in teaching esophageal speech. It's kind of a hard thing to learn on the patient side and a hard thing to teach. I have had a handful of patients that weren't able to use an electrolarynx well for a variety of reasons, weren't able to get a TEP for a variety of reasons, and kind of learned how to do it on their own. But it's the minority. So they'll just kind of learn to swallow air down and bring that up from their esophagus, as I said before, like the example of belching, and speak that way. And then this is a really good website, actually, and I refer a lot of patients to this. It's a primarily patient-driven website that has like a lot of tips on how to live after you have your voice box removed. And seemingly simple things like taking a shower. Well, hey, my trachea is open right here. What the heck do I do? So you can put saran wrap over your neck and not breathe for 10 minutes. And there's different devices available and things like that. And then this is what I was talking about before in terms of a code situation. I mean, after a laryngectomy, this is your whole trachea, your whole airway, whereas, obviously in the normal situation, you're breathing, you're swallowing through your mouth, and your airflow goes down through your larynx. And those are side by side, a laryngectomy tube on the left, and the more normal Shiley, say 6 or whatever, CFS tube on the right, which on the outside you can't really tell the difference unless you look at the letters. And it's been a lot of years, but as I said before, there have been code situations where, somebody died, and I think usually in a code the sheets come down, but I know that in this one situation the patient, was basically covered up to their neck as they're trying to intubate, and they didn't see that there was a stoma here, and they couldn't find the larynx to put a tube in. And you obviously can't mask either. So different complications, and fistula is the main thing that we worry about because, as I showed before, we're taking the whole throat apart, so that really has to heal before they can start eating. In some cases, in a delayed fashion, more commonly, as things heal, it may tighten up to the point that they're not getting solids down, and in some cases either dilations are needed or even revision surgery. And hypothyroidism, especially if we've got a larger tumor that's broken outside the larynx, the thyroid sits right on top of the trachea in that area and on top of the larynx, so sometimes we remove half or even all of the thyroid. So a lot of those patients will become hypothyroid at some point. If it's not right after the surgery, then down the road after the radiation may affect the thyroid. And hypocalcemia for the same reason if we're operating in and around the thyroid on both sides. So that's that, okay. So any other questions or weird instances on previous head and neck patients that you had questions about?
Or yeah, I was going to ask you the same question. Any pet peeves that we should be made aware of from the nursing side, care-wise?
Really? No. I'm chuckling because I know Dr. Lee is coming tomorrow, but when I was speaking to him on Monday, all he said is, just tell them not to compress the flap pedicle. He does a lot of our free flaps. But no, I mean, nothing specific really. I didn't have a picture of it, and I don't know if he'll talk about that. And one of the other things that comes up commonly, in any of our procedures, there's a risk of hematoma. When we use a pectoralis flap, we're folding a big piece of muscle up into the neck. There's always a very large bulge of muscle going over the clavicle, so it's kind of a joke by the residents that we very frequently get called for a hematoma in the neck because of the flap pedicle. So now we actually usually will draw on the patient and say, write down flap pedicle, that sort of thing. But again, that's a pedicle, like a big thick piece of muscle, whereas with a free flap, when they talk about the pedicle, it's really just the artery and vein they have connected up in the neck.
Okay.
So, and you mentioned the flap checks and everything, and we were supposed to get a patient the other day with the flap checks. So are we still not getting them?
No, we will get them, and Dr. Lee's coming tomorrow to talk about the flaps.
Oh, okay. Got it. Because this girl was giving me a report, and she was talking about the flap checks and the Dopplers, and I was like, I do not know anything
So
about any of this.
They'll talk more about it, but there's
Okay.
there's a coupler or a probe like right on the vessel that then comes out through the skin, and it's
Right.
really just it's hooked up to the Doppler box,
Right.
and there's usually 2 channels, one to listen to the artery, one to listen to the vein. So
Okay, and that's what you're doing every hour, you're just checking that, turn
Right,
it on.
although usually by the time they get to the floor, and I don't exactly know their protocols, but by the time they get to the floor, it's probably like every 2 hours or something like 2 or 3
Okay.
hours, something like that.
Okay.
And then the team, when they come by, just to double check, if you will, beyond just the Doppler.
Mhm.
In some cases, especially the venous signal on the Doppler can be kind of finicky. And,
Yeah.
arterial, you hear a nice pulse, but the vein, it's a little bit more subjective.
Sure.
So just to verify things, they'll also come by at least a few times a day and literally prick the flap with a needle and just
Okay.
see what, how quickly blood comes out. Is it venous looking blood? Is it arterial looking blood? And again, by the time they get to the floor, it's not done as much, but
Right.
those are things
And
that are
they,
still done.
they, I think, had taken the arterial line out for the Dopplers, and then they
Mhm.
had the venous Doppler or something like that, but anyways, good to know.
More to come.
Yes.
So most of these patients would probably come to us in progressive care.
Yes. I mean, if they're coming right out of the unit, but again, I mean, some of the smaller procedures wouldn't necessarily come through the unit.
And this person was coming from C7. To us, since we're ENT now. John Potter.
One thing that we learned last week, and I followed up with Dr. Lee about, is we don't have this one situation last week. Orders weren't put in regarding JP drainage and how often and what to look for and when to freak out drainage, rise or mount.
Right.
The resident had written a note. So there were no orders, but there was a note. And we just had some concerns about that. So Dr. Lee's suggestion was for me to follow up with that resident specific. Do you guys have order sets that you follow, or?
I can't say I'm as familiar as I should be with what they're putting in, but usually I think they're just putting in, empty and record Q blank, Q3, Q6 or something like that. So I don't think they would necessarily put into an order like what to look for and that sort of thing.
This in particular, they wanted us to strip the drain, which is not something that we normally do. So,
And it was just in the resident note, not an order. So, yeah, it's just clarifying with the resident what the expectation is. Yeah, okay.
Yeah, so they need to specify. Yeah, I honestly, I was under the impression that we just do that when we round a couple times a day. I don't know, unless it was a special situation where they had a little bit more clotting than they
we
wanted
thought
to
the
see
patient
or
was going to go
something.
home with it, and
Mhm.
I don't fully know what ended up happening with it.
Residents say the darndest things.
I know.
Wait,
Crazy
90%.
things in those clinical notes.
Yeah. Questions, concerns? Do you feel more comfortable?
Nobody said yes.
Just a little.
Nobody said no.
I did, but I'm not at the bedside. No, it's very helpful. It's,
Yes, very appreciated.
Is there gonna be, I'm not here tomorrow.
Yeah, we'll
But will there
take-
be a PowerPoint or,
Yes, and we'll tape him again.
okay.
Yeah.
Thank you.
Yeah.
This is big time. I mean, the taping and everything.
Do you
Did
feel
you say it's
okay
going to be on YouTube?
Yeah, we'll put it on YouTube and then I'll
So I'll
share it
tell
with the
my
staff. Yeah, that's right.
I'll go from being incredibly, tragically uncool to a little bit less.
That's right.
Next up is your Walk of Fame star.
Yeah.
Do you have that outside?
It's,
Dr. Young must have
next
one, I
week.
mean, I assume.
Obviously.
It's probably the Harry Young Walk of Fame. All right.
Well, thank you very much.
Thank you all.
Thank you.